Can you hear
Our
me
next
and see
talk is
me?
going to be by Dr. Alex Chebl. He's going to talk to us about carotid revascularization, the past, the present, and the future. Dr. Chebl is a good friend of mine, and he received the Bachelor of Science from with high distinction and honors in cellular and molecular biology from University of Michigan and Harvard. He then earned his medical degree from Case Western Reserve University School of Medicine following a year of medical internship in San Francisco. He moved to Boston and trained in neurology at the Tufts University Union Medical Center as a chief resident over there, then returned to Cleveland Clinic um, to Cleveland in 1999 to be in fellowship training at the Cleveland Clinic Foundation. There, he completed 3 fellowships in stroke, neurocritical care, and interventional neurology. Dr. Chebl was one of the first interventional neurologists in the world and the first recipient of the American Society for Neuroimaging, Agus Moniz Interventional Neurology Fellowship. He was the co-founder of the Society of Vascular Interventional Neurology, the Society for the Neurologist Interventional Group and Vascular Neurology Group, and served as its first vice president. After serving as faculty at Cleveland Clinic for 5 years, he moved to University of Louisville, where he achieved the rank of professor. There, he developed the neurointerventional program into a thriving academic and clinical practice. Currently, he's the director of the Harris Comprehensive Stroke Center and the head of the Division of Vascular Neurology at the Henry Ford Health System in Detroit. He's also the president-elect of the Intersocietal Accreditation Commission for Carotid Artery Stenting Board. Dr. Chebl specializes in medical and endovascular treatment of cerebrovascular disease, both hemorrhagic and ischemic. He has published numerous articles. It's truly a delight, a treat, an honor to have Dr. Chebl talk to us about carotid revascularization, more than 20 years of experience. Alex?
Thank you, Tony. It's great to speak to you in New York. Although I'm not there, I wish I was. I'm on call, so if my phone goes off, hopefully the fellow will answer. But it's a pleasure to talk to you about carotid artery stenting, past, present, and future. Here are my disclosures that are relevant to this talk. And so let's talk about carotid artery disease, the most common cause of artery-to-artery embolism and large artery stroke, certainly in the developed world. And we know from the NASCET trial, really a landmark trial in the history of clinical medicine, one of the first true evidence-based trials, that endarterectomy is superior to medical therapy in patients with a symptomatic stenosis greater than 70%. And the risk reduction is somewhere around 13% per year with revascularization. The treatment of carotid artery disease for a long time really consisted of carotid endarterectomy. And in symptomatic patients, we know that the risk of stroke is earliest shortly after initial stroke. You see here within 14 days, the risk of stroke is roughly 12%. And this will be important when we talk about timing of revascularization later. And in asymptomatic disease, there were several trials that showed that there is, in fact, benefit for endarterectomy in patients with asymptomatic carotid stenosis, principally those in the 60 to 70% range and greater. A word about percent stenosis. We seem to be stuck on percent stenosis, but really there are many other factors that contribute to the risk of stroke. And as a vascular neurologist, I look at all of these factors in making a treatment decision. Things from plaque morphology, silent embolism, contralateral disease, the status of collateral flow, status of cerebrovascular reserve, inflammatory markers, et cetera, et cetera. And so all of these contribute to the risk of stroke, and we should not base treatment decisions purely on percent stenosis. And I have treated plenty of 30% stenosis patients with stenting or stenting for surgery because they kept on having recurrent stroke for a variety of reasons. And so let's move beyond merely the percent stenosis. And a quick word about imaging. Many patients are treated or treatment decisions are made based on a non-invasive test, a carotid duplex, a CTA or MRA. And I will tell you that I think that that's not appropriate. You should really get at least 2 non-invasive studies, preferably a diagnostic angiogram before making a treatment decision. This has been reviewed, and approximately 20% of patients who are operated on based purely on a carotid duplex will have been operated on inappropriately. So combining 2 techniques, I think, is very helpful. They each have their strengths and weaknesses. So what about medical management for carotid artery disease? And so we know that there's a plethora of medications, ACE inhibitors, statins, the new PCSK9 inhibitors, exercise, smoking cessation, etc. All of these things will reduce the risk of stroke. Right? So appropriately, there are randomized trials of these. The trouble is that risk factor control, particularly in the United States, well, I shouldn't say particularly in the United States, across the world is poor. But even in the United States, somewhere like 22.5% up to 40% of patients with hypertension have uncontrolled hypertension. And let's not forget about cigarette smoking, sedentary lifestyle, etc. And so medical therapy is not as easy as it would seem. And you have to have robust compliance for patients to benefit from the medical therapy. Right? So let's talk about the level 1 evidence showing superiority of medical therapy versus revascularization in symptomatic and asymptomatic patients. Okay, so let me show you the data. Oops, wait a minute. Did I forget to include it? Oh no, I didn't. There are no data. There's 0 level 1 evidence that even modern best medical therapy is superior to revascularization. The CREST-2 trial will hopefully answer this question to some degree, but currently no data supports that approach. We have to do medical therapy, but we don't know that it's superior to revascularization in those patients. All right, so let's talk about carotid endarterectomy, really the standard since the mid-1950s for carotid revascularization. And this is generally how it's done. I don't do carotid endarterectomy, so I'll rely on these photographs. The surgeon incises the carotid artery, removes the plaque, and then hopefully places a patch, angioplasty, stitches the artery back up, and then the patient recovers. And we've talked already about NASCET, really a landmark trial. And in NASCET, the medical arm in the patients with a greater than 70% angiographically proven symptomatic stenosis, the 2-year stroke risk was 26%. And the absolute benefit, risk reduction of endarterectomy was 17%. That's a pretty robust reduction in stroke risk. Okay. There was also the ECST trial showed a less robust but still strong benefit from endarterectomy. And then there was also the VA cooperative study that showed a significant benefit in surgery. So there's really no doubt that in patients with a symptomatic severe stenosis, carotid endarterectomy is effective. The American Heart Association recommends endarterectomy in patients who are symptomatic as long as the peri-procedural stroke risk, so 30-day stroke death MI, is less than 6%. Okay. Now, what about asymptomatic patients? ACAS was one of the landmark trials that showed benefit, and basically it reduced the stroke risk, the 5-year stroke risk, from 11% to 5.1%. So roughly an annual stroke risk of 2.2% was reduced to roughly 1% with endarterectomy. This is in patients with a greater than 60% stenosis, benefit a little bit less in women, more robust in those with more severe stenoses. And then the ACST trial also had comparable benefit with a reduction in the annual stroke rate from roughly 2.4% to 1.3%. So asymptomatic carotids also benefit from revascularization. Right? I told you I would come back to the timing. In the vascular surgery community for a long time, there was this notion that you had to delay revascularization following a stroke to avoid the risk of hemorrhage. And what you see here basically is that treatment under 2 weeks from the ictus, from the initial stroke, is superior to delaying treatment. Okay? And so really there is now hardly any justification for delaying treatment unless the patient has a severely disabling stroke, massive stroke, most of the hemisphere involved, then in those cases it probably makes sense to delay. Otherwise, you want to perform endarterectomy as soon as you can following revascularization. But let's talk about how we got here. And for all those positive trials, we had multiple negative trials of carotid endarterectomy. And it's important to understand why that is, because that will really impact our understanding of the more novel therapies such as carotid artery stenting and TCAR. So why did we have negative trials? It really comes down to patient selection, as well as procedural selection. In NASCET, only a third of the patients who were operated on at the enrolling sites were actually in the trial. In ACAS, 25 patients were screened for everyone that was enrolled. Okay, and we also know that some necks are very unfriendly. Patients who've had radiation therapy, prior endarterectomy, contralateral occlusions, etc. These are higher risk and more challenging for the surgeons. And so it makes sense, therefore, that some patients may be too high risk for carotid endarterectomy. Okay, and this is really important here, is that the randomized trials of endarterectomy, as are the randomized trials of carotid stenting and TCAR, although there aren't any randomized trials of TCAR, really represent outcomes of a healthy subset of patients with carotid disease, and the results are not really applicable to the typical patient, particularly CEA, where most of the trials were in low surgical risk patients. So let's talk about carotid artery stenting. Carotid artery stenting was really developed as a way to treat the high surgical risk patients, and that's performed typically transfemorally or transradially. You do an angiogram here, and you see on the panel to your left a severe stenosis of the internal carotid artery. Here I am performing the procedure, and in this case I was using a proximal floor arrest with a distal balloon to act as a filter. The stent is placed and flow is restored. A minimally invasive procedure. Right? And the first really important trial of carotid artery stenting that showed benefit was the Sapphire trial. This is a much maligned trial because it was sponsored by industry, but this was a trial of patients who were high surgical risk. And what it showed is that stenting was not inferior to surgery, although numerically the complication rate, death, stroke, MI, was substantially lower than it was in the CEA arm, and it appeared to be very durable out to 3 years. And so Sapphire was the first trial that showed that protected carotid artery stenting, particularly that word protected is important. Emboli prevention devices were used with carotid artery stenting, could benefit patients who are high surgical risk. And the restenosis risk was pretty low compared with surgery. The next important study was really a registry. It was a real-world experience of 6,300 patients, but there was independent clinical event adjudication. And what this showed is that there was the event rate with transfemoral carotid artery stenting was low. But the really important trial was the CREST trial. This was a randomized trial, initially of symptomatic patients, but then later modified to include asymptomatic patients. And what I want you to focus on here is that in CREST, 96% of patients with a stent had an emboli prevention device placed, and both the surgeons and interventionalists were vetted and had to submit cases. I had done approximately 400 to 500 carotid stents at the time that I wanted to participate in this trial, yet I had to submit 50 cases. I had to perform 20 cases in the lead-in phase before I was even considered for randomization in that trial. So this was very important. And what the primary endpoint of any death, stroke, MI within the procedural period was no different between carotid artery stenting and carotid endarterectomy. And out to 4 years, similarly, there was no difference in that primary endpoint. Right? So these seemed comparable. Now, there was a difference in the stroke rate, unfortunately, with a higher stroke rate in the stenting arm and a higher MI rate in the CEA arm. But still, for paraprocedural stroke, the majority of the difference was really minor stroke. Major stroke was not significantly different. Still, even a minor stroke can be disabling, and carotid revascularization is supposed to prevent stroke, and so it's really terrible that the thing we're trying to prevent is the thing that complicates our procedures the most, and so we really have to work on reducing stroke rate. However, when you look at the CREST trial, and if you look at the outcomes based on age, roughly around the age of 65, the trial would have been positive in favor of carotid artery stenting for younger patients. So now we're beginning to see maybe for carotid artery stenting, there are also higher risk categories of patients. And in the CREST trial and all the trials will tell you crossing the aortic arch in a patient with severe calcification, severe tortuosity, etc. Those patients may not be optimally treated with stenting. Maybe surgery or even TCAR would be the better option. And so in addition, if we look at the latter half of the trial, CREST would have been positive in favor of stenting because as there was increasing experience with the procedure, the stroke rates were dropping during the trial, and they dropped significantly. Okay, so a brief word about EVA3S, SPACE, and ICSS. These are these European trials that basically destroyed the field of carotid artery stenting. And the trouble with these trials is that they did not have good methodology. So in EVA3S, for example, the interventionalists needed to have done 5 carotid stents in their entire career, but even if they had only done 3, they were allowed to enroll if they performed 2 while proctored. Okay, in the SPACE trial, patients did not have to have had any prior carotid artery stenting experience. They just needed to have done 25 angioplasties anywhere. Angioplasty in the leg was sufficient. And with all due respect to my vascular surgery colleagues, angioplasty of the leg is very difficult, but the consequences of failure are substantially different between failure in the leg and failure in their brain. And so experience is very important. In SPACE, 71% of patients did not have embolic prevention devices. Why? That's kind of like jumping out of an airplane without a parachute and hoping that there's a net somewhere on the ground. Doesn't make any sense. In ICSS, aspirin Plavix were recommended. Who puts a stent inside an artery without dual antiplatelet protection, inhibition? I don't know, but they did. Similarly, poor vetting of the procedures. And so those trials, which were included in multiple meta-analyses, convinced everyone that stenting should not be performed. I don't think it's appropriate to look at any meta-analysis that includes a trial, even though randomized, and even if published in New England Journal of Medicine, that is poorly conducted. It's not appropriate. Garbage in equals garbage out. And just to emphasize the importance of experience, look at this study here, where you see that the complication rates drop once you start getting to like 500 to 600 cases, not 5. And so experience matters when doing particularly complex procedures in the neurovasculature. Okay, now some data regarding different types of stents. There may be benefit in using these mesh stents as opposed to standard stents, so these data are not very consistent. And the thinking being that these stents that have a fine mesh prevent plaque protrusion during the procedure and after. So stay tuned. There's now a device commercially available in the United States, and so we'll see what our experience with it shows. Okay. But what's really changed, or the future for carotid stenting really is with improved embolic protection. And if you look at when do strokes occur with stenting, they occur during the procedure. And the majority occurs during the post-dilation. And so a former colleague of mine came up with this idea of having a combined filter, stent, and balloon on one device. And this was tested in the Performance 2 trial, a prospective study, 305 patients, independent adjudication of events. And what you see, there was 0 major stroke. Okay, which is fantastic. Minor stroke was 1.3%. And so the stroke rate in the Performance 2 trial is about the lowest we've ever seen. And when I show you the TCAR data, you'll see it's very low as well. And so this seems to be a very promising new approach to transfemoral or transradial carotid artery stenting. For the sake of time, I'm going to skip through this here. And just to put it in perspective, if you look at the stroke rates, for example, in Sapphire, in CEA rates in Sapphire, even CREST, the performance 2 outcome measures are the lowest that we've really seen in any prospective study. Okay. Now, what about the timing of carotid artery stenting? Earlier is better. However, it may be that in the first 1 to 2 days, the risks are higher, perhaps in the first 7 days. And so probably carotid artery stenting, if it can be delayed, should be delayed for 7 days or so, and then performed. And that's where the patients derive the most benefit. If you wait too long, 14 days, for example, you begin to lose some of that benefit. And so again, earlier is better than later. All right. So let's talk about TCAR, transcarotid artery revascularization. So TCAR was really developed as a way to bypass the aortic arch. And this is basically a hybrid approach. The vascular surgeon cuts down on the carotid artery and then places a sheath in the carotid artery and is able to protect the brain by inflating a balloon and setting up a retrograde circuit so that there's no antegrade flow, so emboli can't go to the brain. And what you see here is that there have been no randomized trials, but there have been some prospective registries. And compared to, so the Roadster trial, which was the trial that led to FDA approval, had 208 patients. The majority of whom were asymptomatic, all were high risk for CEA. And what you see is the stroke rate was 1.4%, stroke and death was 2.8%. So really very low complication rates. There was a cranial nerve injury rate of 0.7%, but compared to most endarterectomy studies, where that's in the 4 to 6% range, that's substantially lower than endarterectomy. So this looked very promising. And in comparison with endarterectomy in the Society of Vascular Surgery VQI surveillance project, you see that the TCAR stroke death MI rates were really comparable with carotid endarterectomy. So TCAR seems to be at least as good as CEA, certainly in the real world. Now, these registries here, these are all self-reported, and so the event rates here will probably be lower than any registry or study that has independent adjudication of events. Okay. Now, in Michigan, the BMC2 Cardiovascular Consortium has been collecting data prospectively, again, self-reported, and we see that there's not a substantial difference in stroke rate between CEA, transfemoral CAS, and TCAR being 1.5, and 1%. However, for some reason, in symptomatic patients, there was an increased rate of mortality in the transfemoral carotid artery stenting arm, and that led to this significant difference in MI, stroke, and death in symptomatic patients, with TCAR and CEA being comparable, but transfemoral carotid artery stenting being higher. One possible explanation for this, of course, is that transfemoral CAS is riskier, perhaps is being done too early. The other, and I think probably better explains it, is that after the publication of those trials, the experience with transfemoral carotid artery stenting has really dropped significantly, particularly with cardiology and vascular surgery. Us in the neurovascular community, we've continued to do it. And so it may be that it was lack of experience with this approach, which really, as I showed you, requires a lot of experience to achieve good outcomes, but that's a hypothesis. Okay, so controversies. Well, there are plenty of controversies. I assume you have lots of vascular surgeons in the audience, and I'm glad that I'm now several hundred miles away from New York City. I know New Yorkers can throw things pretty far, but all kidding aside, can we extrapolate results of carotid revascularization randomized trials to our patients? This is very important. And the answer is maybe. If you look at mortality, so this is a trial from 1998. This was 113,000 Medicare patients, retrospective chart reviews, but they looked at mortality alone. All right. So mortality is a pretty hard endpoint, and it's not vague at all, right? Patient died, you know it. And so in green here, I have the mortality rate in ACAS. So for asymptomatic patients, it was 0.1%, and in NASAD, it was 0.6%. In the same hospitals that participated in those trials, mortality was 1.4%. In non-trial hospitals, 1.7%, and low-volume hospitals, 2.5%. What this tells you is that real-world experience does not, or often does not, duplicate randomized trial experience, and it's got to be patient selection as well as operator experience, and that's very important. Right? And this is another way to look at it, looking at the various trials, patients who would have met the trial criteria. You see it's highly variable with some patients only 20% meeting the CREST-2 criteria, for example, 47% meeting CREST-1 criteria. So a lot of patients are treated who do not meet the criteria for the randomized trials that led to the approval of the procedure. So patient selection is very important. However, reassuringly, if we look at all of the published studies and registries, on the left here is endarterectomy from 1970 to 2016, and on the right is carotid artery stenting transfemoral from 2000 to about 2016. You see that overall the death and stroke rates are dropping. And again, this speaks to experience, both the proceduralist as well as hospital experience, perhaps improvements in anesthesia, antiplatelet therapy, the variety of different things that have improved in medical care. So overall, we're achieving better outcomes than we did just 20, 30 years ago. All right. What about asymptomatic patients? Should they be revascularized? And I don't know the answer to that. I think the answer is if the patient meets criteria for the ACAS trial, for example, is otherwise healthy, under the age of 80, has a long life expectancy, I think it's reasonable to offer revascularization. That's controversial because we already mentioned that medical therapy, modern medical therapy, is highly effective at reducing stroke rates. And if you're going to argue that medical therapy is superior to revascularization, it's probably going to be in the asymptomatic patients. And so the SPACE-2 trial is ongoing. We don't have results yet. And CREST-2 is also ongoing. We should hopefully have results in a year, I want to say, some preliminary results. And so this was a trial, multiple arms, carotid artery stenting plus medical therapy versus medical therapy, and CEA plus medical therapy versus medical therapy. And so we'll see what comes out of the CREST-2 trial, which really had strong medical treatment arm, statins driving LDL less than 70, ACE inhibitors, blood pressure control, etc. All right. So let's come back and talk about this. Is TCAR really equivalent to superior to traditional carotid artery stenting and CEA? And so, if you look at this surveillance project, it looks like TCAR is superior to transfemoral stenting. I already mentioned the limitations with experience. And as we said, these are operator-reported outcomes. So it may be, but I think if you look at published series from highly experienced transfemoral or transradial carotid stenters, those outcomes are probably comparable to TCAR. But certainly TCAR does look like it's at least equivalent, possibly superior to transfemoral carotid artery stenting. However, in the same projects, typically they include TIA as an outcome. And if you just look at hard endpoints, classic endpoints that were used in other trials, for example, in this study published by Malas in 2018, ipsilateral stroke, p-value 0.33, no difference. Total stroke, no difference. Stroke death, no difference. Stroke death MI, no difference. The differences here, and many authors and supporters of TCAR will say, oh, it's superior. It really comes in TIA. And are these real TIAs? We don't know. TIA is really not an endpoint in most stroke trials because there are many things that are called TIA that really aren't TIA. So if you look at the hard endpoints, in my opinion, my interpretation of the data, TCAR and transfemoral CAS, if performed in experienced hands, are probably comparable. All right. What about GDMT? Should it be expanded beyond antiplatelets and statin therapy? I don't know. There are no randomized trials, so I'm just going to skip that one. What about how can we incorporate shared decision making? Why shared decision making? So recently, CMS, which had previously declined to cover carotid artery stenting, expanded coverage to basically all symptomatic patients greater than 50% and asymptomatic patients greater than 70%. Okay. However, the coverage decision required shared decision making. And I think this is very important. What does shared decision making mean? It means that you must discuss all treatment options with a patient, CA, TCAR, and CAS. And optimally, the patient should see specialists who perform all of those procedures and then make a decision. And I think that's very important to include patient choice and making sure that they have a true understanding of the risk. So that's what we mean by shared decision making, and I think that's critical. Okay, but let's come back to when you have your discussion with a patient. I think you can also tell patients that sometimes some procedures are not appropriate. So we know, for example, patients who have had radical neck dissection, radiation therapy, prior endarterectomy, etc. Those patients don't do as well with CEA, with cranial neuropathy rates of 18 to 20%. Patients with contralateral occlusion in NASET, the periprocedural stroke rate was 18%. Now I know with modern surgical approaches and monitoring, that's probably substantially lower, but that's what the evidence base says. Similarly, for transfemoral carotid artery stenting, tortuosity, severe calcification, coagulopathies, long lesions, the very elderly may not do as well with transfemoral carotid artery stenting. And with TCAR, similar challenges, sort of a combination of both of the above. You have to do a cut down. Common carotid artery disease, calcification can be a challenge if the lesion is very low and there's not enough room to insert the sheath. And so really you need to understand all of these, and then for each patient, tell them which procedures they're high risk for, which procedures they're not. And then if there's clearly one that they are lowest risk for, that should be what they should have. And I think this is very important to discuss with our patients. All right, so that's sort of the past and present. What about the future? I think the management of chronic internal carotid artery occlusion is very exciting. It's something that I've been treating or trying to master the technique of treating for about 23 years now. And the incidence of carotid artery occlusion is roughly 6 per 100,000. That accounts for 15 to 20,000 strokes per year. And the prognosis is pretty poor, with high stroke rates, high mortality. And so this is a disease that really needs treatment. And so why? Well, because these patients can present with a variety of different manifestations, typically hemodynamic TIAs, shaking limb TIAs, TIAs when they stand up, hemodynamic strokes, embolic stroke, the Ferlin-Wisnat sign, that's light-induced visual loss due to retinal ischemia. When patients see very bright light, particularly the sun, that can be a manifestation of poor flow to the retina. Horner syndromes, and then of course patients present with acute occlusion. So on the neurovascular side, we treat acute stroke patients on a regular basis with carotid occlusion. Here I'm really focusing on those patients who have chronic occlusion, who have events. And in order to know which patients you should treat, you really have to understand the mechanism of ischemia. I think this is very important, okay? Not all stroke is the same. Some stroke occurs due to thrombotic occlusion. You've got acute plaque rupture, thrombosis, vessel occlusion, ischemia. Some stroke occurs due to artery embolism. You just have a ruptured plaque or a piece of calcium that shears off the vessel, flies downstream, lands in a distal vessel, and then you get occlusion. Some stroke is due to hypoperfusion. Really, this is sort of autoregulatory failure, and impaired cerebrovascular reserve can be associated with a stroke rate as high as 25%, depending on how you define it, PET, SPECT, CTP, etc. But really, I think a lot of patients have a combination. This is what Luke Kaplan and Michael Henrici called washout of emboli. I really love this paper of theirs. And they posit that patients with severe stenosis, or occlusion, are having ongoing microemboli, but due to the decrease in the pressure head, those emboli lodge in the border zones and aren't washed out. And hence, if you look at MRI scans, those patients will have what's called a border zone stroke. But this is important to understand because if you've got thrombosis, right, then anticoagulation, antithrombotic therapy, dual antiplatelet therapy, probably better still, will be effective in reducing stroke risk to some degree. If your mechanism of ischemia is hypoperfusion purely, well, then all the antiplatelets in the world aren't going to help you, right? You need restoration of flow. So understanding the mechanism of ischemia in each particular patient is critical for understanding what the next step in treatment is. So what are treatment options for carotid occlusion? So I showed you what the risks are with medical therapy, very high risk. Surgical treatment, which can consist of a variety of different techniques here. This illustration is showing SCA to MCA direct bypass. So here the carotid artery is occluded. The surgeon takes the superficial temporal artery and then sutures it onto an M2 branch of the middle cerebral artery, restoring flow. Okay, and there are several other variations of this, some which take longer. Okay. And so there was a trial of this in 1984, and that trial was sadly very negative. However, this was not purely patients with carotid occlusion. This included patients with stenosis. And you see the medical arm stroke rate was 24% versus 44% in the surgical arm. And the theory as to why this trial was negative was because they included patients who had stenosis rather than complete occlusion, is there was antegrade flow, and the flow is lowest at the region of stenosis. So when you do a bypass downstream of the stenosis, now you have retrograde flow competing with antegrade flow. Where is the zone of zero flow? Well, it's probably in the region of the stenosis. And so these patients then were thrombosing off their carotids and middle cerebral arteries. And so certainly bypass is not a good option for stenosis. But there have been two modern trials, COS and CMOS. The COS trial, I think, was a good attempt, but flawed, primarily because I enrolled a lot of patients in the COS trial, but many more patients I sent for bypass because they could not tolerate waiting for the PET scan to be done 2 to 4 weeks after discharge. They kept on having hemodynamic events. And so I think the COS trial selected out the patients who were going to benefit the most from treatment. Most of those were treated early on. And the CMOS trial was also showing actually some benefit, but they use CT perfusion, and CT perfusion is overly sensitive. But not very specific for impaired cerebrovascular reserve. So I think we can do better. But currently, bypass is really not proven and is not the standard of care. But I think it should still be offered for patients who have recurrent hemodynamic TIAs. Okay, so what about endovascular therapy? Well, in the coronaries, cardiologists have been treating chronic total occlusions for a long time. Vascular surgeons treat chronic total occlusions in the legs as well. And so this is common practice. No one really hesitates. And the approach is relatively straightforward. What you do is you basically drive a wire subintimally. You go around the plaque, re-enter the true lumen, and then you angioplasty and stent, reconstructing the whole vessel. Now, the carotid artery is not a leg and not a coronary, and the consequences of re-entry intradurally or dissecting the carotid artery can be catastrophic. And so this is not straightforward. But there were some case reports, mostly from Asia, Japan, and showing that it's been successful. So I started to do this back in 2002, and I've since collected 31 patients. Yeah, I know it's not a lot of patients, which is why I've waited a long time to try to publish this. I thought 31 is not enough, but all these patients had symptomatic carotid occlusion with decreased cerebrovascular reserve. You see most of them presented with stroke or hemodynamic TIAs. The mean occlusion duration was 228 days, maximum of 1,020 days, and most of them were around age 65. And here's the success rate, 96.6% technical success rate. That includes 4 patients who failed the first attempt, came back on the second attempt, And then I was a successful 75% of those cases. And so you don't succeed always the first time, but you can always come back. The 30-day stroke death rate, 3.4%. That's pretty darn good when you compare that, say, with COS or other trials of bypass for carotid occlusion. There were 3 cases of distal embolization, none of which were symptomatic. Okay, and there was 1 carotid cavernous fistula that resolved. There was 1 case of cervical extravasation, and that sounds terrible, but actually, if you pull the wire out, if you don't do an angioplasty, it will stop on its own. The vessel will shut down. There were some cases of dysphagia and dysarthria. Both of these were, one patient had a 360-degree loop in the carotid artery that when I stented, I straightened it out. And so I definitely pinched the hypoglossal nerve there somehow, or and actually not the hypoglossal, I'm sorry, the recurrent laryngeal nerve. And so the patient had dysphagia. And so it's not without risk, but I think in the grand scheme of things, it's probably reasonable. And here's the long-term follow-up. My range is up to 39 months. You see that the recurrent stroke rate was 3.4%. This was a patient who came in, I think 15 months after initial treatment. He was not compliant with his medications. And so certainly 3.4% is substantially lower than the expected stroke rate for patients with carotid artery occlusion. Restenosis is not insubstantial, roughly about 16%, but all of it was asymptomatic. And so I'm not sure that all of them need treatment, but the majority of patients with restenosis were patients who, for some reason or another, I did not stent the entire ICA. When I do these endovascular reconstructions, I typically will stent from the cavernous all the way to the bulb, basically full metal jacket, multiple overlapping stents. And if you don't do that, there's a higher risk of restenosis. There is a risk of occlusion. There was a couple of years ago, a presentation from experience from Europe where the reocclusion rate was 25%. I've simply not seen that. And I think the reason is, again, that stenting of the entire vessel, as well as confirmation of adequate dual platelet inhibition during the procedure. So I think it really makes the procedure safe and durable. So here's a case. This patient, 72 years old, had coronary artery disease, multiple risk factors, recurrent expressive aphasia, hemiparesis, had an ICA occlusion, was given medical therapy. The events recurred. At the time, I used transcranial Doppler that showed decreased cerebrovascular reserve. And here's what our angiogram showed. Here's the right carotid artery. You see that although there's collateral flow to the ACA, there really was no filling of the left MCA. And here's her left ICA, complete occlusion at the bulb, and there's recanalization via the ophthalmic artery here via collateral flow. So this collateral flow was not sufficient to meet her needs. I'm not going to belabor the approach. Here it is, the carotid completely reconstructed, restored antegrade flow, and the events resolved completely. So I think the management of chronic total occlusion is really the future for carotid artery disease. And I will finish on time. I did my best, Tony. To conclude, we really have an expanding array of medical therapies for treatment of patients with carotid disease, but we really need level 1 evidence that it's superior to revascularization. So hopefully the CREST trial will give us that. Carotid artery stenting and CA have similar aggregate procedural risks and similar long-term effectiveness. And in here, really, I'm including TCAR. I mean, really, TCAR is carotid stenting, but you're just not doing it transfemorally, okay? There are high-risk patients who would benefit from one approach rather than another, and I think it's important to have that discussion. And there are new devices now, like this combined filter stent balloon that may further reduce procedural risks. Thank you very much. I'll take questions if we have time.
Wow, this is such an amazing talk. Cover a topic from 2 decades ago now to now, and looking to the future, what to come. Thank you so much, Alex. That's amazing. I wish you could be here to
I wish as well, but my partners would be very mad if I left and didn't cover all the.
We understand that. But you're safe in in Detroit. So I'm going to
Right.
ask you some pointed questions.
All right.
So our vascular surgeon will not be able to chase after you.
Okay.
So if you have to predict, do you think the combined device with stent, filter, and balloon altogether, presumably with improved filter pore size than currently we're using available without post-dilatation angioplasty. Do you think that will actually approach the TCAR or be superior in TCAR? In other words, it's going to be the battles of titans. Who's going to be the first-line treatment?
Yeah, I know. I think it will. I mean, if you look at the Performance 2 data, TCAR was approved without a randomized trial, right? It was a prospective registry, prospective study. Similarly, Performance 2 with this integrated embolic protection, and the event rates were actually comparable or a little bit lower than with TCAR. So I really think this is a game changer. And you can do this now, and actually per the FDA, you have to do with dual protection, either a distal filter, but I've been doing it with a proximal balloon occlusion with a guide catheter, and then you cross the lesion with a wire, deploy the new filter. Now you've got proximal flow arrest and a filter, and I think their event rates will be very low. Someone's asking a question in the audience. I don't know if you want to.
Yes. Is there ever a time when you delay carotid revascularization after acute stroke? For example, patients with very irregular plaque, intraplaque hemorrhage, etc., to still treat acutely within 2 weeks or before a course of antiplatelet anticoagulation?
Yes, so it depends on what the approach is going to be. If the patient is a good candidate for endarterectomy and they are not severely disabled, they don't have a massive stroke, we typically will try not to delay. I think from endarterectomy perspective, no reason to delay. If they have an event and their best option is a carotid stent, then we try to delay 7 days or so if possible. However, we see patients who are frequently having recurrent events, and if their stroke burden is very low, their MRI does not show any SWI lesions, we can control their blood pressure. Based on our experience, we're comfortable treating early. And I am very aware of the risk of hyperperfusion. When I was in Cleveland, we wrote a paper with 850 patients showing that you can essentially prevent hyperperfusion in ICH with tight blood pressure control. So I think if you have a good ICU, good blood pressure control, you can treat early. But yes, some patients you might want to delay.
Great. What do you think the reason is for the difference treating with a transfemoral stenting, within 7 days or after 7 days, but within 2 weeks? There seems to be a time window that's optimal, but we're not seeing that for the carotid endarterectomy.
Yeah, so I think it's probably some of those patients will have a thrombus, intraluminal thrombus. And if you don't use good technique while crossing, you're probably more likely to send that downstream. Secondly, you have to use dual antiplatelet therapy, so some of those events will have been hemorrhagic. And so, patients with a very big lesion, maybe significant petechial hemorrhagic conversion, maybe those patients will have a higher risk. But I really think it comes down to experience. If you look at outcomes at large centers that do a lot of acute stenting, we've not seen the complication rates at 7 days. So I really think that operator experience also plays a role.
Great. Any other questions? If not, one last one. Do you think the combined device will be able to be introduced in trials like CREST-2 if it's been approved by the FDA? Because that potentially be a game changer, can affect the comparisons, the dynamic comparisons of the different arms.
Well, so unfortunately, CREST-2 has stopped enrolling, so it will not be introduced in CREST-2. And I wonder now that there is a broad coverage decision, will there really ever be a randomized trial? I'm just not sure. I think that the best approach is similar to what's happened with TCAR, is using registries, following patients prospectively, reporting on outcomes, and seeing if you can reduce event rates that way. And so the device is going to be marketed or sold by Medtronic, and I'm just not sure how much Medtronic is going to invest in more research on this. I'm not saying they're not, we just don't know. So hopefully they will invest more research, because there are really a lot of unanswered questions.
Great. Thank you so much, Alex. Truly appreciate that.
Thank you very much. Thank you all. Have a great meeting, Tony.